So lots of politics, but there's also a regulatory component to this as well. And this summer, CMS announced a proposed rule for sort of, I guess, modernizing, if you will, at least some people have referred to it that way, Medicaid. Regulations around things like access, around enrollment, financing and such. Thoughts of any of you on the panel about CMS's proposed rule for Medicaid and what impact that might have?
I think it's gonna have a huge impact because very, very clearly managed care is the direction that Medicaid is going. And again, it may look a little different depending on what state you're in, but in essence, all states are moving towards some kind of managed care. And I think the genesis or the impetus behind the regulations, it's a recognition from the administration that they didn't really have a very good handle on what was happening. It's like they looked out and they realized that the barn doors were open and horses were running in 50 different directions. And they have to be accountable for what's happening, and they realized that they weren't. And so this is an attempt to sort of close the barn door, re-corral the horses, and kind of get everybody on the same page. And I think some of the changes will come as no surprise to people who have been doing managed care for a little while. Some of the changes, a lot of our members have said, well, this is kind of veering in the direction of a little bit too much one-size-fits-all federal focus, which you understand because that's easier to regulate, but the concern is that going to stifle innovation? Is that going to create a ceiling on what can be done rather than a floor?
And yet Medicaid, I mean, the feds are responding to criticism that they haven't been paying attention enough. And I think the success of managed care depends on a really vigorous accountability agenda because people are appropriately distrustful. You know, I mean, it's a new way of doing things. There's going to be a lot of pushback from people that are used to working only in fee-for-service and in a different situation. So I think it's the best way. It's like an inoculation to have serious accountability for the future success of these entities.
Yeah, and I think to a certain extent, Peggy is absolutely right in that the move towards managed care must be done thoughtfully, and managed care, as my members have said, it's a tool. It is a means to an end. It is not the end itself. And you can't simply say, oh, we're going to go do managed care and then hand over a book of business to a managed care entity and say, here's 1 million people, here's $1 billion, go do your best. You're going to have to do it thoughtfully. You're going to have aggressive oversight, monitoring. Those things are happening at the state level. So I don't, because there have been a lot of very important lessons learned and failures along the way. Again, the question will be, is this the right way to do it? And how do you balance the need for CMS as an administrator to look out and to monitor versus the fact that the conditions on the ground in an Arizona, in a Tennessee, in a Delaware are all very, very different.
So let's play that out in one particular dimension, let's say the access dimension, because that's one that gets a lot of attention. You do have a lot of variation in terms of the delivery system across the country. Access is one thing where people have concerns, a little bit of distrust. I mean, how does this play out on a topic like that?
Well, access in classic Medicaid hasn't been great because of the low rates paid to providers. So actually, often in managed care plans, they get paid better, and therefore there are broader networks, ironically, in Medicaid.
Yet there's also been some discussion about narrow networks as well as we sort of see this play forward.
Yeah, access has been a long-standing issue in Medicaid, both managed care and fee-for-service. And it's a complex issue because access for primary care is different than access for specialists. Home benefits are different. You can measure access in various ways, whether it's by miles, by waiting time, whether you do secret shopper where you kind of call offices and see who takes what, or whether you poll or survey beneficiaries and see what their limitations are in getting access. So it's incredibly complex. And states, there was an HHS IG report this year or late last year that documented that access is, it's variously measured across states, it's variously enforced. Some states don't really have standards, some states do, the standards vary. And I looked to the new regs to see what they're doing about access, and maybe other members of the panel can speak to this. I was a little bit, I had a hard time getting a handle on it because it looked a little bit vague and aspirational, and putting a lot back to the states, saying, well, you know, you have to have a plan in place to have standards to measure access, but not really specifying what that needs to look like. And I'm curious how this will play out. And you know, I don't know if other folks
I
have
think
some.
for us, and we've just gone through a revision of our standards around access, we want to be careful not to kind of jump in with both feet and prematurely set up an environment that squashes the ability to do telemedicine, for example, and so forth. We actually defer to the plans that they have to have access standards for various types of physicians and providers. And then we're looking to see, are they following their own guidance? And we're also having them do special studies that we're going to then ask them for. So we're monitoring the situation much more closely because we've been in a period of very, very broad network access and so forth. So it's kind of a new day for us. But I think that the NAIC also is really trying to be cautious, trying to be responsible, and we're not at the end game yet, but trying to make sure that things are okay in the short term too.